All right, it is 11:31. Good morning, everyone. Thank you for joining us today at the Center on Democracy, Development, and the Rule of Law at Stanford University. This is our regular seminar series that meets every Thursday at 11:30, and Leah and I are coming to you today from hot and smoky California. We hope that wherever you are, you and your loved ones are safe. We have a postdoctoral program at CDDRL every year that brings in talented recent PhDs to work on topics critical to democracy and development. This year we have Leah Rosenzweig as one of our postdoctoral fellows, who is at CDDRL and also the Graduate School of Business's Golub Capital Social Impact Lab. She received her PhD in political science from MIT, the Massachusetts Institute of Technology, where she was a National Science Foundation Graduate Research Fellow, and she was a research fellow for the past 2 years at the Institute for Advanced Study in Toulouse, France. Today, she's going to be talking about some of her recent work on COVID-19 and the pandemic in East and West Africa. So without further ado, Leah, and if you have any questions, please ask in the Q&A box and we'll be sure to get to them with plenty of time. Thank you.
Great, thanks Dee. Thanks everyone for tuning in, and I hope paying attention, though I can't see, so look forward to your questions at the end. So today I'll be presenting what is a culmination of a lot of different data collection efforts by myself and many collaborators in 3 countries in East and West Africa. And so I'm going to try and pull out key themes and lessons learned from our data collection efforts about the response to the COVID-19 pandemic in these countries, and the response both from government and from citizens. And I think that we can draw a lot of lessons that are applicable beyond the COVID pandemic, that we can generalize about citizen-state relations during crises and beyond. So as many of us know, as we're sort of currently living the pandemic, when COVID came about, sort of every nation, every national and subnational government needed to respond. They needed to both keep citizens safe, but also had to make hard trade-offs with respect to keeping economies running, ensuring kids are getting an education, people can sort of keep making an income, feed their families, things like that. And so as you can see here, the photo on the left is from Uganda. Uganda instituted a national lockdown early on in the pandemic and actually prohibited public transportation very early on as well. So as you can see here, this woman is working at a stall in a market and had to actually sleep in her stall in order to work because she wasn't able to travel home and to work. And on the right is an image from Nigeria, which also instituted a national lockdown in 3 states. Nigeria is a federal system, so the national government instituted a lockdown in 3 states, and then in other states, they sort of managed their own lockdowns subnationally. And the other country that I'll talk about today is Sierra Leone, which instituted a few sort of shorter periods of national lockdown of 3 days each. So as we can see from this map and the cases I just mentioned, there is a wide variety of government response to the pandemic. So this map is showing you data from Oxford's COVID-19 government response tracker that measures government stringency from a 0 to 100 scale, where 100 being the darker blue is sort of the most stringent policy measures put in place. So this is from September, but if we looked back over the course since earlier on in the pandemic, there's been a lot of variation in government response, both across space and time. And so the motivation for this project today is not, the typical academic research question where we're testing a theory, we have sort of theory-driven questions. Rather, it was, a bunch of social scientists coming together at the beginning of the pandemic, thinking about how we could use our skill set as social scientists to help. And we thought, what better way to do that than to try and gather data that could help support evidence-based policymaking. And so we did this in 3 countries, Sierra Leone, Nigeria, and Uganda. And mostly because we had existing connections to decision makers on the ground in these 3 countries, we also have a unique opportunity to leverage a lot of existing data sources, given that we were in this context of it being unable to do in-person data collection. So in Sierra Leone, we conducted a nationally representative survey of a little over 2,000 respondents, starting in mid-April, and we actually just concluded a second wave. And we were actually lucky to be able to get out in person for the baseline survey. When Sierra Leone had only one case of COVID-19, we got approval from MIT IRB and the ethics committee in country along with the Stats Sierra Leone to do this. We were taking, the most stringent health precautions for our enumerators. And because we were doing this in collaboration with government, we were able to, at the same time, distribute buckets for water, for hand washing, and soap. The other data collection we did was in Kampala, Uganda. So at the city level, we have a representative panel survey of just under 2,000 respondents. This was building on existing work by my collaborators at WZB Berlin, who had done an in-person baseline survey earlier. And finally, at the state level in Lagos, Nigeria, where we've been and are still in the process of doing a quota-based sampling technique where we're essentially cold calling people on the phone using a survey firm in country that has access to 70 million phone numbers in the country to reach people. So again, I should mention that this was done in close collaboration with many partners, both government, policy, research advocates in each of these countries. So together with our government partners, we designed survey topics and questions around themes and topics that were useful for their decision-making on the ground. So for instance, how long can people survive lockdown, questions of food insecurity, access to water. And in Sierra Leone in particular, these questions went into policy briefs that we designed and disseminated with the government that actually informed the rapid response the government was doing and informed the government's decision to make a sort of 3-day lockdown period, because we found that only 60% or a majority of citizens could only prepare and store food for 3 days at a maximum. We also looked at the subnational level where we asked questions about community mobilization. So Sierra Leone experienced Ebola in 2014, 2015. And so existing communities had mobilized groups already in place that could lend themselves to the COVID-19 outbreak. And so we found, where government might be able to leverage those existing groups and where they might need to go in and sort of do their own information dissemination. We also asked questions about trust in authorities and information about coronavirus. People could name most of the symptoms, understand how it spread. But for the purpose of today's talk, I want to move a little bit beyond what we did for the sort of rapid response for decision makers on the ground to looking more of a long view as to what are the policies that need to be put in place for sort of living with COVID, not just fighting the outbreak immediately. So for this, we asked a bunch of questions related to compliance with policies and expectations of others' attitudes and behavior. So this is what I'm going to focus on for the rest of the talk today. And so here again, I think we can generalize from some of these lessons learned to other crises on the continent and beyond sort of crisis situations. So the first question we had is, are citizens complying with health policies? So our comparative advantages as political scientists is we understand perhaps why, what makes people comply or not with government decisions. So, things related to trust, legitimacy of the government, things like that. And in the case of COVID, we experienced a lot of policies that took top-down enforcement from the government, but also policies that require more of a quasi-voluntary compliance, require citizens to be the ones to say, yes, I'm going to comply. I'm going to do this for my benefit, for the benefit of my community. So one of those policies is mask wearing. Whether or not it's sort of a legal rule in many of these countries, it's still something that's being recommended by the WHO and many governing bodies. So we asked people, the last time you left your house, did you wear a mask? And as you can see here, very few people reported to us that they did not wear a mask the last time they left their home, which might not be surprising to any of us. We know that there are problems with this kind of direct response in terms of social desirability bias. So citizens thinking that, they just want to give the answer they think we want to hear, which is that, yes, I wore a mask. But we also used indirect reporting techniques, what's known as a list experiment, where we asked people not to tell us exactly what they did or did not do, but in a sort of list of 4 or 5 things, tell us how many of those things you did. And we randomized people to get a list with or without the quote unquote sensitive item, which in this case was not wearing a mask. And so using this statistical technique, we found that in Lagos, it looks like, around 18% of our respondents actually did not wear a mask, which is, higher than we got with these self-reported measures. We did the same kind of list experiment in Kampala, but the results are to be determined after we submit our pre-analysis plan. So it looks like for the most part, despite the challenges with self-reported measures, it seems like a majority of citizens are wearing masks. But when we ask in a slightly different or more nuanced way, when we ask, understanding that some people are not able to wear masks all the time. So giving people, respondents, a kind of an out to say that they didn't, to what extent did you wear a mask that fully covered your nose and mouth, we see a lot more variation. So, again, only a small 2% of people said they never wear a mask. But we see, a majority, about 53%, are in the middle around half the time. And so this, I think, is good news. We see that most, about half of the citizens are wearing masks all of the time. A majority of citizens are usually wearing masks. And so we're now trying to think about creative ways to get more of a ground truth or objective measure of this. For instance, asking respondents to send us selfies if we text them a quick survey at a random time, or sending enumerators out into the field, either in a personal vehicle or in a safe way, to sort of count or take photos of the number of people they see wearing masks. Again, because we can't always rely on people's self-reported behaviors. So the second question we were interested in is, are citizens social distancing? And similarly, we asked, direct questions about, in the past 7 days, how many times have you done these things? So in Lagos, our respondents said that, about 3 times in the past 7 days, they came within 2 meters of someone outside their household, which of course could be just due to a lack of inability to social or physically distance. Lagos is an incredibly dense city. And so some people just by necessity, if you walk outside of your house, or even if you're within your house, it's hard to maintain distance from others. People also report sort of using public transport twice in the past 7 days and attending religious services once. Now, of course, it's hard for us to understand how this compares to sort of what we would ideally want, which is at a baseline level of these behaviors pre-pandemic, which we don't have in this case. In this case, we're working with the NCDC in Nigeria to access CDR or call detail record data to get an objective measure of mobility in the city. And in Sierra Leone, we actually have access to this data. So through our government connections, we were able to get call detail record data for one of 2 main network providers in Sierra Leone. So what this data is when you're on your phone, either you're making a text or making a call, when you do that, your cell phone pings the nearest tower. And so using the map of towers, we can understand how people are moving from place to place. And so what this data, this graph is showing is on the x-axis is time, and on the y-axis is this distance index, looking at the % change in average distance per trip. Compared to a baseline level in February. So here's the 0 line. And so we can see that, in February and early March, it was about average, fluctuating above and below our baseline measure. But then in early April, when the start of this first official national lockdown happened, we see a precipitous drop in mobility, which is good news for compliance, right? So we see in this instance of sort of top-down, heavily enforced compliance, there was indeed quite a drop in mobility, which interestingly goes right back up to where it was pre-lockdown, which makes sense if you think that there was a lot of uncertainty around whether or not there was going to be another lockdown and how quickly that would happen. So people need to go out of their home to get groceries, visit friends, maybe travel to, a home up country, something like that. But what's particularly interesting for us is that we see this, again, a drop in mobility after the lockdown. So here, this is not government instituting a national policy, but it's rather more of a voluntary compliance among citizens to reduce their mobility. So this is something we're interested in looking more into, both at sort of subnational variation and variation over time. So for the most part, both in terms of mask wearing and social or physical distancing, it seems like people are complying. So what might be the explanation for that? Well, first, we see in our data that citizens are indeed well informed, both about the symptoms of COVID-19. They can name sort of the top 3 symptoms, and they know how it spreads through, air droplets in the air. They also think that wearing a mask is effective. So 85% of our respondents in Kampala and 92% of respondents in Lagos believe that wearing a mask will help reduce the spread of coronavirus. 89% of Sierra Leoneans believe the government has the heart to provide high quality healthcare. So what's interesting is that we seem to see that citizens are both informed about the disease, the best preventative measures, and trust the government's intentions to sort of help them overcome this problem. Now, of course, there's a difference between trusting government intentions and trusting government's capacity to execute those intentions, which we also asked about. And there's some more variation there, but it's interesting sort of in a context in which we might think, trusting government might go way down depending on how you think the government's handling the situation. I think we've seen some of that in the United States. Here, and in fact, in many of these countries, trusting government seems to remain relatively high. But beyond the sort of traditional political science or social science explanations for compliance, trust and legitimacy, knowledge, all of that, there also seems to be a potential other explanation. So among Kampala respondents, we asked about how concerned they would be, to what extent they would be concerned if other people in their village saw them outside of their home without a mask on. And 72% of respondents said they were very concerned that others would see them without a mask. And this sort of makes sense because in the context of COVID-19, we have this collective action problem where, individuals might not want to incur a cost wearing a mask, which is uncomfortable, for the greater good or their common good, keeping a community safe. But we're all better off if everyone complies, yet there's this desire to free ride. And so we might think that my individual behavior would be influenced by how I think others will perceive me if I do or do not comply. And so here we see some indication that citizens are concerned about how their neighbors will view them if they are not wearing a mask. Similarly, we see that 40% say that others would view them as a threat. 25% say that they would be seen as irresponsible if they're not wearing a mask. 82% of respondents say that people who wear masks are seen as health conscious, and 31% they are seen as responsible citizens. So here we see this indication that not only are citizens sort of concerned about how they'll be viewed by their peers, but mask wearing is seen as sort of a positive thing to do that responsible citizens do, and not wearing a mask is seen as a quite negative thing. So we might ask the question then, is there sort of a social norm of mask wearing? So I study social norms, in particular social norms of voting in Uganda and Tanzania. That's what my book project is on at the moment. So there are two ways that two good indicators to see if there's a social norm. And these were developed by Christina Bicchieri at UPenn. The first is that citizens should have empirical expectations. So we should think that others will behave a certain way, meaning others will be wearing masks. So we asked people, out of 10 other community members, how many of them do you think wear a mask when they leave their home? And so here in the dark blue, we see that a majority, our respondents think that a majority of citizens in their communities are wearing masks. And what's interesting is, again, in the light blue, is their own self-reported mask wearing behavior. And so this is sort of like the phenomenon where everyone thinks they're an above average driver. Majority of respondents always say they're above average, but of course that can't actually be the case. So there is a phenomenon going on that might be, of course I wear my mask, but only about 50% of other people do. But still we see that, I expect that a majority, though, just over the majority of other citizens are wearing their masks. So I do have these empirical expectations in each of these countries. The second indicator of a social norm is that we should have normative expectations. So not only is it enough to say that I think everyone else is wearing a mask, But I also need to believe that everyone else thinks we all should be wearing a mask, that they are these normative expectations at play. And we also find this. So in Lagos and Kampala, a majority of respondents think that a majority of people in their local community believe that everyone should be wearing a mask. So this is, again, sort of just initial indication of a social norm of voting, a social norm of mask wearing in some of these countries. And at the moment, we're digging into sort of subnational variation in this. In my other work, I've sort of thought a lot about how variation in the strength and existence of social norms varies, and came up with this idea of social dependency. So meaning how much I rely on and depend on other community members will motivate me to comply with any social norm. Because if I rely on my neighbors to watch my kids when I travel or for information or kinship ties, if I then face social sanctions, I'm going to incur a high cost to try and find the benefits I get from my peers elsewhere. So we're looking into some of these things here as well. So it does seem like citizens are complying. We've reviewed some of the explanations for why that might be the case. But of course, in any context, and especially in COVID-19, where even a minimal amount of non-compliance can be quite dangerous in terms of super spreaders and people just sort of breaking herd immunity, we might want to then ask, how can governments encourage policy compliance? And this is actually an article from Science Magazine that mentioned some of the work we're doing and a lot of other behavioral scientists working in this area. So there are a couple strategies governments normally use to encourage compliance. The first is coercion and force, the sort of proverbial stick. And we've seen this, in some countries more than others with response to COVID in terms of, enforcing top-down policies and actually using force, police presence to do so. But I think, in many cases, quite quickly, we see governments sort of shifting to the other strategy, which is more sort of positive inducements and incentives, or the carrot version of encouraging compliance. And in reality, governments probably use a mix of both. But there might be, particular reasons why in some of these countries, they might, prefer to use carrot over the stick, whether that's either due to a lack of state capacity to sort of have a police presence everywhere to induce enforcement, or if they're worried about their international reputations, especially if they're planning on requesting aid from other countries or bilateral aid agencies. So we focus on the carrot for these studies. And in particular, we look at sort of nudging with messaging. Messaging can be used in a number of ways. So it's sort of an easy way for government to quickly and sort of publicly en masse get out, the information it's trying to convey. So then the question becomes, first, who is the right messenger? And second, what is the right message? So with respect to answering this first question, we conducted what is called an endorsement experiment, where we sort of vary the actor that is said to be condoning or endorsing the behavior. And so this is data from Sierra Leone. So we here varied the messenger, whether it was government, international NGOs, traditional leaders, or religious leaders. And so you can imagine, why we chose these actors. One, because governments and NGOs are often working in tandem in health crises. They did so during the Ebola outbreak. Religious leaders are often used as intermediaries during public health crises. And traditional leaders are, in particular chiefs in Sierra Leone, are powerful informal leaders as well. So we varied and randomized respondents to see one of these authorities saying that travel might need to be restricted for some time, even if it means it will be hard to find your daily bread, and ask respondents, on this scale, whether or not they agree or disagree with this policy. And so here what we see is that the government messaging, people who saw that the government was endorsing and saying that travel might need to be restricted, actually were more positive towards this policy than any of the other actors. So, somewhat surprising, we think, that again, sort of trust in government seems to be high. Messaging from government as opposed to these other authorities seems to make people more positive towards these policies. So we're asking this same question in the second wave that we just completed, so we'll be able to track change over time and also look at subnational variation if there are differences in urban-rural attitudes with respect to these questions. So we also conducted a similar endorsement experiment with respect to a mask-wearing policy. And so these data are from Lagos, where we again asked about government, both federal and state, WHO experts, and religious leaders. And surprisingly, again, we find that government performs better, and in fact, statistically significantly better than religious leaders, which I find actually quite surprising, given that, I've done work on the polio epidemic in northern Nigeria, where it was actually critical that the government engage religious leaders to help, put out information, but also gain compliance with vaccination. But here we see that, either the government or the federal government or the state government both perform much better than religious leaders. And in Kampala, we asked similar endorsement experiments, which I can't show to you yet, but we also asked about, just general self-reported, again, agreement with mandatory mask wearing. And again, we see 94% of respondents say they agree with the mask wearing policy, but they think only 66% of other community members agree with this law. So this is some indication that if that's 94% is true, or perhaps even if it's not, true, it is reported by respondents themselves, and maybe the government could use this to sort of change people's priors about others' agreement with different kinds of laws. So this is something that I've looked into with a couple of co-authors, and we conducted a Facebook experiment and survey early on in the pandemic in Uganda, Kenya, and Nigeria. And what we find is that indeed, not only with mask wearing in these countries, but also with attitudes towards a lockdown policy, people severely underestimate how favorable their peers are to these policies. And yet, citizens are very willing to write their own messages to their compatriots, encouraging physical and social distancing. So I just want to share a couple of those. So these are directly from our respondents who said things like, please, let's practice social distancing, not only to save Kenya, but to save the whole world. The more you engage in physical distancing, the lower your chances of getting coronavirus. It's physical distancing, not emotional distancing. It doesn't affect your relationship, and relationships are no good for the dead. Stay alive by engaging in physical distancing. So one strategy that governments might want to take is just taking the words from their own citizens in terms of, these might be the most compelling messages. But sort of moving beyond what peers might say to each other, what is the right message? So we've seen examples from government itself that sort of vary in what we might consider quality. This was a Facebook post that said, staying at home to prevent COVID-19 is not imprisonment. Might not be the best idea to sort of associate imprisonment with staying at home, but the government quickly learned, and sort of this is a WHO and government message that sort of used the cachet of a soccer player that was encouraging people to dab or cover your nose and mouth when you sneeze or cough. So we wanted to test some messages that, thinking about social science theories might be encouraging to citizens. And we did so taking, again, the sort of longer view and looking at specifically compliance with vaccination. And again, we weren't thinking about specifically, coronavirus vaccination, since that doesn't yet exist, but more generally, just vaccination as a sort of general measure of compliance. And so we thought about priming citizens based on this idea that there's a shared identity. So as Lagosians, we have a responsibility to keep all of Lagos healthy. Again, in the context of a collective action problem that COVID-19 presents, this might be salient to people. We also tried sort of highlighting law and order, saying that the government has been working hard to keep the public healthy by making sure people who endanger public health are caught. And we talked about government responsiveness. So the government has been working hard to respond to the health needs of the public. So in this experiment, a respondent either read one of these three messages, or they were in the control condition that just said, now I would like to ask you a question about vaccines. And then we asked the question, how unwilling or willing would you be to let your child get routine vaccinations now? And again, these data are from Lagos, which is still in process, but the sort of early indication from the data suggests that compared to the control condition, both the identity and sort of highlighting government's efforts to respond to the public health needs do better than just the control condition of saying nothing. So some indication of the way government could do, might do better to sort of message its citizens and garner compliance. So quickly to summarize, we've seen that most citizens seem to be complying with key health policies, which is, great for reducing disease burden. Messages, I think surprisingly, but interestingly, should come from government rather than from other authorities. And not only have we seen that in one country, but we see that in sort of all of the countries that we looked at. So it's not just the case that sort of in competitive democracies like Sierra Leone, but also in sort of single party or dominant party states like Lagos at the subnational level. Messages emphasizing shared identity and government responsiveness may improve compliance. And we think that there's some evidence that peer-to-peer messaging and social influence also may have a role in encouraging compliance and could be a strategy that government could adopt. So very quickly, just a couple next steps. We're continuing these data collection efforts. We're combining the CDR data with the sort of self-reported mobility and distancing measures to see how those compare. And we're exploring variation in the presence and strength of norms of compliance. And in other work, I'm also looking at the coronavirus infodemic and thinking about how we can nudge people towards better online behavior, sort of trying to reduce the spread or the sharing of fake COVID cures. So with that, I think a lot of collaborators, a lot of partners on these projects. Thanks to DRL for having me, and thank you all for listening.
Excellent, Leah. Thank you so much. That was really informative, and one can't help but think about the United States and all of the variation that we've seen in mask policies and guidance as well. So you'll probably have a question about that in a second, but let's go ahead and start. Frank Fukuyama, our director at CDDRL, is asking if you have any evidence of why compliance deteriorates over time. Maybe it's the need to return to work, or its peer effects, or some weakening over time of enforcement capacity.
Yeah, that's a great question, Frank. I think it's all of the above, honestly. I mean, I'm sure as many of us can also attest, it's quite tiring to comply with many of these things for a long time. I think it's also a question about expectations, right? So I think early on we thought that, this might be a phenomenon for a few months, then we'd have a vaccine or it would go away. Obviously that's not the case. So I think now is honestly the more critical time to sort of find the best way to sort of revamp compliance, say, changing expectations, saying we might not have a vaccine in the next few months, year, whenever, and these are the ways we can keep ourselves, our families, our community safe, and trying to figure out sort of exciting and new ways to get people to continue complying with these things. Yeah.
A sort of follow-up to that from Eric Jensen is that your presentation focuses on the voluntary compliance element of compliance, but did your research also try to quantify the extent of coercive compliance across these three countries? And I know you said it was less effective, but could you talk a little bit more about that?
Yeah, so we only asked really about coercive compliance in Uganda, and I'll maybe just leave it at that. You can interpret as you want. But so we asked about, whether or not people were familiar with the sort of formal sanctions that you would face if you were caught outside of your home without a mask, or you were caught outside during the lockdown. And I don't know that we asked explicitly about sort of personal experiences with forced compliance, but I will have to look into that because it would be interesting indeed to compare people's sort of perceptions of government enforcement and their own voluntary compliance.
Okay. Nate Grubman is asking if you have ideas on how compliance with these public health policies should be compared to compliance with other policies like taxation, especially thinking about the relative importance of either trust in government or pro-social norms.
Yeah, that's a great question. So we similarly asked these kinds of endorsement experiments for a range of compliance policies. So one being vaccination, which is sort of the most relevant for COVID, but we also asked about taxation as well. We asked about sort of reporting to the police. And I think there was perhaps one other one, but yes, so our plan is to compare how these endorsement experiments varied depending on what kind of compliance we're talking about, whether that's health related, security related, or taxation. So we're very interested to see what that looks like.
Okay, so a question that I had and that Alberto Diaz-Cayeras is also asking is about state capacity. So it's interesting, you're definitely right, that the government was the actor that got the highest level of compliance in your experiments. Is there any way in your surveys to know whether the credibility of governments is somehow due to the way they've dealt with Ebola in the past, for example, how prior crises and experiences shaped government capacity in this regard? And do we know whether effective state capacity is objective and not just a matter of citizen beliefs?
Oh, good questions. I definitely think, I mean, my hunch is that there is sort of some path dependency, and how people experience, for instance, the Ebola outbreak, especially in Sierra Leone, is informing, you know, how they, both what they expected government to do in terms of responding to the COVID pandemic. Perhaps they had really low expectations of government initially, and then, you know, turns out maybe government exceeded their expectations, and that's sort of giving them a bump in sort of trusting government and then compliance. That could be one thing. We have some data from Sierra Leone pre-pandemic that would allow us to look at the extent of experience with the Ebola pandemic and also trusting government. So that's something that we can look at to see if that's correlated with today's sort of trusting government. But yeah, it's a tricky question about sort of how objective attitudes about state capacity and intentions is.
Okay, there's a follow-up to that from Brett Carter. If the questions about government, trust in government versus trust in other religious and traditional leaders showed that it was so high, do you think it's perhaps a measure of preference falsification, or is there variation according to the party that's in power, or variation based on other sort of immediate political factors? You mentioned that there is some variation in the type of party system or regime in all of these countries. So could you say a little bit more about your research?
Yeah, so there's definitely some variation. I think in Sierra Leone, at least, we don't find, for instance, that among opposition supporters or opposition-led areas that, you know, the endorsement experiment is very different. And actually, the government seems to be still doing pretty well. In terms of preference falsification, that could absolutely be the case. You know, we always ask at the end of these surveys, you know, who do you think sent us to do this survey? And there's always, you know, some percent of people say the government. So we can, you know, subset out those people and see, you know, among those people who thought we were coming from the government, do we see, you know, even higher sort of positive attitudes towards government? That's something I will look at.
I'm going to take a little break and ask you to maybe stop sharing your screen, or do you mind if I stop sharing it for you?
Yes.
Let's try this. There you are. Excellent. Okay, so onward with the questions. So far, COVID rates and deaths have been surprisingly low in Sub-Saharan Africa, according to one of our questioners. Do you think this is attributable to prior experience with Ebola, which I know we've mentioned a little bit before, but if you could say a little bit more qualitatively of how governments responded then? Do you think it's a matter of consistent government messaging and policy, or do you think it's underreporting? We know that case counts are being reported in a highly varied way across even the OECD advanced democracies. Or do you think that it's people maybe realize there are some weaknesses in the public health system or in the medical system, and therefore are more willing to engage in behavioral sort of non-pharmaceutical interventions?
Yeah, that's a really tricky question. I'm going to give a really unsatisfactory answer, which is I think it's a lot of things at once. You know, I think it's like, you know, a lot of these countries didn't have sort of their first case of coronavirus until later, you know, in the sort of global trajectory. I think these governments, especially Sierra Leone, you know, totally benefited from their experience in the Ebola outbreak. So they had community organizations, groups sort of already set up. They knew what sort of rapid response looked like. and did a lot of things very well, similar for Nigeria, which actually performed quite well on Ebola as well. Of course, I think there's, under testing, under reporting, all of those things to varying degrees in cases. I think at least in these countries, it's probably less of an issue than, say, for instance, in Tanzania, which is another country I've done a lot of work in, which at some point just stopped reporting data. And then, I think despite all of these sort of good things, there's, the other side of the issue, which is that there is still a lot of misinformation out there. And despite, case numbers being relatively low, there's still people who are turning to traditional modes of medicine, some better than others. And so, I'm not a physician. I can't say if those things are working or not. They're definitely, being called upon to, I think people, across the globe are looking for, any kind of thread for a cure, quote unquote. But yeah, I think it's due to a lot of these things. I think, the expectation for Africa, for the continent, which is, crazy to talk about as a sort of single unit, was that, these countries are not prepared, they don't have the right health equipment, they won't have the right policies. And I think, we dispelled that quite quickly. Governments were ready, and they learned either from themselves in history, from other countries across the globe, and they did a really good job in sort of stepping up and getting citizens on board with information and compliance.
Okay, you did mention the information environment, and we have a question about, it looks like the role that central governments play is really important in managing policy compliance, but do you also see variation in terms of different incentive strategies or addressing the information environment, like propaganda or potentially offering rewards that the government can do to try to mitigate the spread of bad information? And how does the government balance different methods of coercion and incentives and messaging?
My headphones died, so I missed the middle part.
No problem. Basically, just how are governments employing different tactics, both coercion and incentives, and also trying to affect the information environment positively, like how to mitigate the spread of bad information, or have they been using propaganda tactics, etc.?
Yeah, so I think for the most part, at least for our, these countries and our partners, especially, this is something that came up as honestly the #1 issue that the Nigerian CDC has been battling is like the coronavirus infodemic and the spread of false information. And I think the challenge that they, were having, and it sounds like still are having to some extent, was sort of the spread from peer to peer of bad information. So people, setting up their own YouTube channels, propagating their own cures, or, scams came up with like job opportunities or opportunities for aid that were hoaxes. So at least in these cases, I don't think I've seen examples of sort of propaganda. I think any government is probably smart enough to realize that this is also a unique opportunity to sort of gain a bump in trust, in legitimacy, in favorability with its citizens. But I haven't seen sort of concrete examples of propaganda per se, but it is something that the government is trying to combat, at least on the part of citizens and other sort of more nefarious actors.
Okay. So Marcel Faufchamp is asking, you showed that compliance is partially supported by peer pressure. So what about peer pressure regarding symptoms? Like, are people with symptoms afraid to seek healthcare because of a potential attached stigma? Has there been social sanctioning for people not engaging in the right behaviors?
Yeah, so that's something we were concerned about, because it's something that Sierra Leone, in fact, saw during Ebola, is that, healthcare utilization went way down. There were a lot of economists that produced studies on that. So that's something we measured. I don't have the data off the top of my head, so I don't want to say anything about what we've seen there so far, but it's absolutely something we're looking into. The other thing we did, we're concerned about and we're asking about is sort of stigma associated with having coronavirus. So we asked a lot of questions about, if someone in your community had COVID-19 and came back, how would other people in the community sort of see them or react to them? And unfortunately, we are seeing that there does seem to be stigma associated with COVID-19. Again, sort of similar to Ebola, that, people report being less likely to talk to that person, definitely not wanting to touch that person. And yet people still seem to know that, if you get COVID-19, it doesn't mean you have it for life. So there's this kind of juxtaposition between, at least reporting that they know you don't have it for life, you can sort of overcome the disease. But yet, other people in their community, at least, sort of being fearful of talking to or socializing with people who had COVID. So we'll have to see how that plays out.
Okay. A question now from Salma Musa, who's another one of the postdocs at CDDRL. There's a compelling case against lockdowns in developing countries. For instance, the population might typically be young or less at risk, and the need for daily bread may be more pressing. So do you differentiate between lockdown measures like staying at home and then social distancing and mask wearing, like engaging in everyday activities? And a second question is, do you have objective measures of compliance? For instance, could you map survey results to outbreaks and try to infer whether or not compliance is actually working?
Yeah, so on the second question, that's something we're doing in Sierra Leone, because we have sort of both the survey self-reported measures of compliance, then we have the CDR data that gives us at least a measure of mobility and sort of how people are traveling, where they're sort of connecting, and we have disease burden and outbreak in the country. So we're sort of merging all of those pieces of data to do exactly what you suggest, Alma. And yes, absolutely, sort of official lockdown, shelter in place, stay at home policies are absolutely different from just physical distancing. At least in each of these countries, these governments did do a sort of national, or at least in some states, top-down enforced lockdown, stay at home policy. And I think, when Nigeria did that, especially in Lagos, it faced a lot of criticism for exactly the reasons you're suggesting. There's a lot of, young people in Lagos, people who live hand to mouth, like need to be out there working to survive. And I think that's one of the reasons that the government sort of lifted the lockdown perhaps earlier than it otherwise would have. At the same time, governments were cognizant of this trade-off and did try and implement assistance programs that would send out, whether that's water, food, cash to people. I think, at least from our data, citizens were less than thrilled with the way those assistance packages were implemented and played out. But absolutely, there's definitely a difference between those policies and just trying to maintain physical distance between people.
Okay. A question from Tasalia Rizzo, our former postdoc. It seems that COVID is changing our assumptions about what state capacity is. So do you think that the experience with previous epidemics in some countries correlate with wider state capacity on other measures, i.e. was that a state capacity enhancing moment, or was the previous experience contributing to relative success in this crisis through other mechanisms, like some of, especially the social norms that you've described, or social civic organization as well?
Yeah, I think this is a state capacity enhancing moment. I think it a little bit remains to be seen. We can see some of that with our data insofar as, people sort of across both sides of the aisle in these countries seem to be more positive towards government. It's interesting to think about why that's not happening elsewhere, like the United States. But yes, I think this is a state capacity and sort of reputation enhancing moment for sure. But, again, at the same time, these governments were sort of leaning on past experience that they had in health crises, which I think absolutely helped. So, hopefully, for the next, whatever health crisis that is, they're even better prepared.
So along these lines, I'm wondering if you could broaden the scope of the investigation and tell us anything you know about comparative data from other countries that have already experienced this epidemic, those of Western Europe and those in Asia, and of course the United States. do you think that compliance rates or case counts for some of these behavioral interventions are due to effective government messaging in some cases and effective government response, and not, and a failure of those things in others, like the United States, for example?
Yeah. I mean, it's hard to know, for instance, if in the United States, the national federal government came up with like a great sort of nudging campaign slogan that, you know, if liberals, Democrats, whatever, regardless of what your sort of political ideology was, if people could get on board. I think one, it depends what the message is, right? So what I've talked about today in terms of policy compliance are things that, you know, WHO experts are recommending, though of course there was sort of some fuzzy area with mask wearing at the beginning. But, you know, these are things that we would probably all agree are sort of the best practices that everyone should adopt. And so, of course, you know, if it were the case that in these countries the government was recommending something else, that there was dispute over whether that was, you know, something we all should be doing or not, I think it would look quite different. And you could think about looking at these kinds of things with respect to closing schools or when and how to reopen schools. I think, you know, some of these questions are less black and white and more sort of nuanced. And so I think there is where like politics comes into play more, when it's not such a clear cut, you know, this is the indisputable, like best thing or right thing that everyone should be doing. Okay.
And a final question, just as we're wrapping up here, is you did some of this research on behalf of governments, or it's sort of consultative work for governments. What do you think about the way academics can help inform government response? Like, do you know, it's not just through the application of sophisticated methods to try to understand things or testing hypotheses that are useful, but could you just say a little bit more about how that relationship has worked and whether or not you think that governments can adequately create policies once they know a little bit more about how citizens are behaving?
Yes, that's a great question. So I think what we, you know, at least what I learned as an academic, as someone that wants to partner with governments, wants to do research that matters and has an impact in the world, you know, in the context of COVID in the early sort of outbreak stages, governments were incredibly overwhelmed. Like, you know, the Ministry of Health in Uganda could not schedule a meeting with us because they had their own problems to deal with, unsurprisingly, right? So I think what we learned is that, you know, being in the right place at the right time, having the tools sort of in-house to do what you needed, so that it's a quick and easy ask to government, something like, here's our survey questions. Are these the right questions? Are there other topics you're concerned about or would help? In Sierra Leone, you know, there were weekly calls with various ministries just to, you know, observe and hear what kinds of decisions are on the horizon, so that then we could take that back to the drawing board and say, okay, what are the questions we need to ask to get the government the data it needs? So I think especially in these kinds of, you know, emerging crises, academics need to sort of have the tools and skill set ready to go and not be the ones forcing the process, but sort of be there to lend a hand and be flexible enough to sort of pivot and figure out what government needs and to make that a priority. The other thing I will say is about sort of dissemination. This is not the time to write academic papers and those will not be written. So again, sort of thinking about how to design policy briefs, like the best way to disseminate those things. You know, our maps seem to be very useful for decision makers in Sierra Leone, visualizations that are easy to interpret for non-academic audiences. All of that, I think, matters a lot.
Thank you so much, Leah. That's incredibly helpful. And thank you so much for this great research and this presentation today. We look forward to seeing you on campus at some point in real life, in person. And to everybody else out there, thank you for tuning in, and we hope to see you again in the future. Bye,
Thanks,
everyone.